In this lesson, we'll begin looking at the female reproductive system by looking at some uterine structural abnormalities, and then we'll take a look at some menstrual disorders. So let's consider the position of the uterus normally. The uterus is normally anteverted and anteflexed, right? So let's take a look at what that means. This is actually showing a pathology first, but let me just kind of give you a little bit of a review. So the female here is facing anterior. This would be the front, right? This would be posterior in the back, right? This would be like the pubic bone, the urinary bladder. This line here is the urethra, right? Then here's the normal position of the uterus. This would be the vaginal canal right here, right, the opening of the vaginal canal, and then this in the back would be the rectum over here, and the sacrum right there. So normally the uterus is positioned forward over the bladder this way, and see how it's curved, like flexing, right, kind of curved forward, right, and that's what we're talking about. The anteverted and anteflexed, it's going to be positioned forward over the pubic bone, right? That's the normal position. The cervix, which is the lower part of the uterus, that would be like, well, just look at this one here. This is the cervix down over here, is going to be projecting down into the vaginal canal. Right, so it's going to be downward and a bit posterior. So the first condition we want to look at is known as retroflexion. So instead of the uterus being tipped forward, in this case, it's going to be tipped backwards, right? So the uterus is tipped posteriorly. It may be excessively curved or bent also, so that's going to be variable. Right, so that's the picture that we're looking at. They have a couple different degrees here. You can see from normal, it's slightly tipped backwards. Second degree, a little bit more, and then third degree, even more so, pushing up against the sigmoid colon over here. Marked retroversion may actually cause other symptoms or problems such as back pain, dysmenorrhea, which is painful menstruation, dyspareunia, which is painful sexual intercourse. So depending on how bad the retroversion is, these symptoms may appear also. And then in some cases, infertility. Okay, think about, the sperm don't make their way all the way up normally because the uterus is tilted too far backwards. So just to show you a couple other ones, retroflexion and flexion posteriorly. So here, take a look from normal. The uterus is retroflected backwards, but see how it's also flexed the wrong way, right? Remember we said before, the uterus is typically flexed anteriorly like this. Look at this one. The uterus is flexed the wrong way. Okay, so this is retroflexion with flexion posteriorly. Retrocession would be like just taking your chair and then just pushing it straight backwards. So you can see the distance between, say, where the bladder is and the uterus is increased. So that's just called retrocession. And then anteflexion is where the uterus is tipped too far forward. Okay, so those are the positions of the uterus, the possibilities. Let's take a look at something known as prolapse or uterine displacement. This is where the uterus is dropping down into the vaginal canal. We'll go over these types in a second just to kind of give you an idea. So now on this female that's facing the other way, right, here's the pubic bone, bladder, urethra, and here's the uterus, right, and then the vaginal canal would be like in here, and then here would be the sigmoid colon and the rectum. Here's the sacrum, right? So this picture is just facing the other way. So you'll notice from the normal position of the uterus, as it descends down, it drops, right? We'll have a first degree prolapse. Then as it's in the vaginal canal, it's going to be a second, and then actually, protruding, the cervix actually comes out of the vaginal canal, would be a third degree prolapse. All right, so first degree prolapse, the cervix is just dropping down into the vagina, the vaginal canal. The second degree prolapse is going to be the cervix is in the vagina, right? It's in the cervix is at the entrance of the vagina. And then the third degree prolapse is if the uterus and the cervix are actually protruding through the vaginal orifice. Early stages of prolapse may be asymptomatic, and advanced stages obviously are going to cause discomfort, infection, decreased mobility, right? Just a lot of pressure from the uterus being in the vaginal canal. And so this is a good picture kind of showing the 3 degrees. Okay, first, second, and third. Two other conditions, sometimes the rectum can actually press into the posterior aspect of the vagina or the vaginal canal. This is called a rectocele. So let's take a look at that for a second. Again, this one, again, this is going to be the pubic bone, urinary bladder. Again, here's the uterus and the vaginal canal. But look at this time, the actual rectum is pushing forward into the vaginal canal. So this would be a rectocele. And then before we go back to the notes, here the bladder is pushing into the vaginal canal, right? So this would be a cystocele. All right, so rectocele, again, a protrusion of the rectum into the posterior vagina, may cause constipation and pain. And then a cystocele, just from the anterior, is going to be a protrusion of the bladder into the anterior vagina. And this may be a cause of urinary tract infections. If severe, these conditions are treated surgically just to increase the support of the different pelvic ligaments. Right, there's various ligaments that they can tighten and shorten and take some of that pressure from the rectum or the bladder off of the vagina. Okay, so again, cystocele, rectocele. Okay, let's switch over now from structural abnormalities to just some menstrual disorders. The first one we want to look at is amenorrhea. Again, whenever we see the prefix a or an, it means without, right? So this is going to be without menstruation. There's two types basically. The primary form is this is a woman that has never had menstruation. So menarche, which is the first menstruation, has never occurred, right? So we just want to maybe jot down a definition here. Menarche is the first menstrual cycle that takes place. It just never occurs. Right? There's different genetic reasons for this. There's a genetic condition known as Turner syndrome. There could be a defect with the central nervous system, the hypothalamus, and the pituitary. Remember, the hypothalamus and the pituitary are in the central nervous system, and they secrete the hormones necessary for menstruation, things like follicle stimulating hormone, luteinizing hormone. Okay, so if there's some type of defect in this region, or there could be just say a congenital absence of the uterus, right? We're not going to have menstruation then. Secondary amenorrhea is it the cessation of menstruation. So this occurs in a woman that has had menstrual cycles before, but now they stop. Most of the time, this is due to some type of hormonal imbalance. Activity of the hypothalamus may be affected by things like tumors in the brain, stress, sudden weight loss, even eating disorders or decreased body fat. A lot of times, women that are very, very athletic, do extreme competition and things like that, will lose their period for a period of time. So these are secondary, right? So again, these if we get rid of these problems, right, the menstruation will come back. Okay, so that was amenorrhea. Again, a without. Menorrhea is going to be menstruation, right? We don't have menstruation. Dysmenorrhea is a little bit different. This is going to be painful menstruation. So the female is having her menstrual cycles, however, with pain. This also can have two forms, primary and secondary. Let's take a look at primary first. So this is caused by excessive release of different chemicals we have in the body known as prostaglandins. These are chemicals that actually cause like smooth muscle contraction. They're involved with clotting. They're involved with a lot of different pathways in the body. So here, when a woman has her menstruation and she has excessive prostaglandins being produced, this is going to cause dysmenorrhea, right? So the prostaglandins cause strong muscular contractions and the vascular ischemia. Again, during the menstrual cycle, the blood vessels in the endometrium will actually constrict so that the uterine lining will shed off, right? These prostaglandins are involved with that. So typically the pain begins 24 to 48 hours before or at the onset of menses, and and it will last for about 24 to 48 hours, right? So a day or two. One of the medications that's pretty effective are going to be the different NSAIDs like Advil, Motrin, because the way these drugs work is they actually decrease the production of prostaglandins. So again, with primary dysmenorrhea, the problem is just an excessive release of prostaglandins. Just speaking to patients over the years and just learning a little bit about dysmenorrhea, you typically find out that menstrual cramps or dysmenorrhea is worse, when females are younger, in their teens and things like that. As they get older, they tend to go away. It's not always the case, but the amount of the prostaglandins produced decreases over time. So a lot of times these menstrual cramps, right, dysmenorrhea, will subside or at least be reduced. Again, it's not always the case, but just kind of like an informal survey. The second type of dysmenorrhea is secondary dysmenorrhea. This is due to some type of pelvic problem, maybe endometriosis, which we're going to talk about shortly, polyps in the uterus, pelvic inflammatory disease where there's infection inside the uterus or the fallopian tubes, that type of thing. So again, if these things can be corrected, the problem will go away, the dysmenorrhea will go away. Okay, let's take a look at something that's commonly called PMS, right? Premenstrual syndrome. This begins approximately a week before the onset of menses, right? We really don't know what the cause is. It's definitely believed to be, hormonal factors. So how does somebody know if they have PMS? They're going to have different clinical manifestations, things like breast tenderness. Again, this is about a week ahead before the menses come on. Weight gain, abdominal distension and bloating, irritability, they'll be more emotional, sleep disturbances, depression, headache, fatigue, that type of thing. So these are just kind of vague symptoms, and the treatment is just kind of supportive and individualized. Try to have exercise being done, decreasing the salt intake, right? That helps to decrease water retention, that type of thing. Sometimes they'll be put on oral contraceptives, diuretics, or even antidepressant drugs. You may hear this term, I didn't put it in the notes, but when somebody has really severe symptoms, a lot of times they'll call that premenstrual dysphoric syndrome. That's when the symptoms are a bit more severe. All right, so this is PMS. Just a couple other definitions I want to give you related to menstrual bleeding. Um, just to kind of go over here, let's go over these terms. Menorrhagia, this is an increased amount and duration of flow, right? We'll actually use this term in future lessons when we look at some different conditions. So menorrhagia, right? Increased amount and duration of flow. Menorrhagia is bleeding between cycles, right? So you have a normal cycle, now you have extra bleeding in between. Polymenorrhea, this is short cycles of less than 3 weeks, right? So normally, again, you figure a normal cycle would be 4 weeks, 28 days, right? This is going to be shorter cycles. And then oligomenorrhea, these are long cycles lasting more than 6 weeks. Okay, let's take a look at the last condition for this lesson here, known as endometriosis. All right, so this is a condition where we have endometrial tissue that should normally be just inside the uterus, but here it occurs outside the uterus, right, in places that it shouldn't be. One of the problems with this condition is these patches of endometrial tissue that are on the organs and throughout the pelvic cavity, maybe they respond to the normal cyclical hormonal changes. So they respond to FSH and luteinizing hormone and that type of thing, and they'll bleed, and now they're going to bleed into places that we shouldn't have bleeding, right? And that's going to be a definite problem. So the bleeding is going to lead to inflammation and pain, and then over time that bleeding in areas that shouldn't be having blood in it will develop fibrous tissue like scar tissue, and that's going to cause adhesions and obstructions of different structures that are in the area. Okay, so that's the pathology, right? We have endometrial tissue where it should not be. So what are some of the reasons the endometrial tissue gets into other areas? Here's some possible thoughts to this. It's a possible migration of the endometrial tissue through the fallopian tubes, and then the tissue comes out of the fallopian tubes, and let's just say into the the pelvic cavity. It could be the development of embryonic tissue at other sites. So we have tissue that's going to become endometrium, but it's on other sites where it shouldn't be. It could also be spread through the blood and the lymph. And these are kind of thoughts as far as how it gets around. And it could even be transplanted during surgical procedures, maybe something like a C-section or something like that. Okay, so when a female has endometriosis, what are some of the clinical manifestations? They'll have dysmenorrhea. Again, that was the painful menstruation. This would be a type of, again, secondary dysmenorrhea, and dyspareunia, which would be painful intercourse, especially if the endometriosis, excuse me, is into the vagina or the vaginal canal. So the treatment is going to be hormonal suppression. They do different hormone treatments, and they can even take out some of the tissue surgically. So here they're actually showing you, this is kind of like an expanded uterus right here, just in different areas. Some of these uh, purplish patches right here. This is endometrial tissue in places that it shouldn't be. It looks like that over in here, okay, here, over in here. All right, here they're actually showing you. So here, see, here's the uterus, right? This is where we would have the endometrial tissue normally, but it can go down into the cervix. It can go down into, down through the vagina, out into the perineum, which is the pelvic floor. It could be, this is the, I call this the vesico-uterine pouch right here, this little pouch between the uterus and the bladder. Your book is calling it the anterior cul-de-sac. It could be in there. It could be on the appendix, on the colon, on the ileum, the peritoneum, just all over the place on the colon. I call this the recto-uterine pouch. This is what your book is calling the posterior cul-de-sac. This is just like a little recess between the rectum and the uterus. Okay, so that concludes this lesson on structural disorders of the uterus and then menstrual disorders. In our next lesson here, you'll see that we'll look at some infections and then some benign tumors of the reproductive system in the female.